activity as per DAS 28 and 85% was seropositive. So we found out that with 16 weeks of therapy, there was a statistically significant increase in the ApoA1 levels and a statistically significant decline in the ApoB by ApoA1 levels by 7% and a mild 1.5% increase in HDL levels, which was again statistically significant. There was no difference in the other lipid parameters. On dichotomizing the data, we found out that patients with elevated ApoB by ApoA1 ratio more than 0.9 reduced from 21% to 14% in patients with receiving 16 weeks of methotrexate therapy. There was no difference in the proportion of patients with elevated cholesterol, LDL, triglycerides or reduced HDL. We tried to see the associations of these changes and did not find any with obesity, rheumatoid factor, anti-CCP or disease duration. We tried to assess the relation with CRP and we found out that all the lipid parameters had a negative correlation with CRP such that they had a commensurate increase in levels with decline in CRP, the strongest correlation being for ApoA1, which correlates very well mechanistically. However, delta ApoB by ApoA1 was the only parameter which commensurately declined with the decline in CRP and reflected the real state happening inside. We also did adjusted analysis using multivariate regression, and we found out that delta CRP was significantly strongly associated with delta ApoA1 and with a good R square of 0.38. This was, however, not true for delta ApoB, where age was the only parameter independently associated. However, the R square was very low. We tried to see whether there was any difference between treatment responders and non-responders and did not find any change. And thus we concluded that methotrexate exerts a favorable effect on lipid profile in RA through a mild but significant increase in HDL, ApoA1 and a reduction in ApoB by ApoA1. And this could potentially represent one of the mechanisms by which methotrexate exerts its cardioprotective effect. Before I close, I would like to propose some food for thought by proposing that lipid paradox may ultimately not be a paradox if we start measuring the correct parameters like ApoB by ApoA1, because they commensurately decrease with the decrease in inflammation. And these lipoproteins, primarily A1 and the ratio, may be more accurately representing the lipid burden and may potentially be adopted as biomarkers and treatment targets after validation. Just to be certain that this is not all conjecture, so there is ApoA1 gene therapy that has shown remarkable protection against atherosclerosis even in persistent hyperlipidemia in the blood in rabbits. I acknowledge the limitations of my study, which include a short assessment period of only 16 weeks and a relatively small sample size for the question that I am trying to answer. Thus, we plan to assess this over longer term, and the most important thing of correlation with clinical cardiovascular events is the plan and validation with other cohorts. Thank you, and I would like to ask you to invite.
Thank you very much, and this paper is now open for comments, questions, discussion. General Bakuni.
Yes, sir, I can.
And 93% are per female and their age is around 40 years. Okay. So what I presume that study would have been much better had they been beyond 50 years or in post-menopausal women where the lipid profile is already high. See, till the time the menstruation, the lady is menstruating, she's saved, she's, in the safer zone for all these illness. I say lipid profile, they are severe on other diseases, or lifestyle diseases. So the lipid profile, all the parameters are already low, okay, below 40 years of age. So this study would have been much better had you been enrolled the patient who are post-menopausal with rheumatoid arthritis. That's my personal view. I don't know what is your answer to that.
So my take on this would be, I agree with you on this point, but the rationale for selection of this age group was the varying pharmacokinetics and pharmacodynamics of methotrexate in the elderly age group. So because the elderly age group may be more prone to methotrexate side effects, we are more cautious in dosing of methotrexate. So since the primary goal of this study was to study the effect of methotrexate and how it affects the disease and the inflammation in RA, and then see all of those effects without the confounding effects of the other risk factors that you mentioned, like the post-menopausal. That was the intent at the time of inclusion. And secondly, since this was post-hoc, the primary RCT had a different primary goal altogether, and this was a post-hoc analysis. So So that is why I do not include the patients.
So I think better would be if you
Yes.
include those patients.
Right.
Yes, thank you very much. Very nice report. Did you, in your population, did you ask them to do a lifestyle change? So you recommend a low cholesterol, low fat diet? Was that recommended, or they just continue their regular diet?
They were on their pre-morbid diet and lifestyle. No lifestyle interventions were suggested. Not
I think that's important to mention, so that your results become more significant to the reader.
there was no specific intervention, no diet prescription, no exercise prescription, and whatever differences we are seeing are therapeutic.
Thank you.
What proportion of your patients were on corticosteroids, and do you think that could have also affected the lipid levels?
Absolutely, sir. So that's why in the baseline traditional risk factors, when I described, I said that only one patient out of 103 was on low-dose prednisolone 7.5 mg at baseline. Only one out of 300.
Well, that's unusual, but that's what it is. All right. Thank you very much.
Now may I call upon Dr. Nikhil from Lucknow. The title of the abstract is Juvenile Onset Lupus in India Data from a Multi-Institutional Inception Cohort of SLE. Over to you.
Good morning, everyone. Today I'll be presenting data on juvenile lupus, systemic lupus erythematosus from these 10 institutes in inception cohort from the INSPIRE on SLE in India for research. Actually,
I think we need some technical help.
despite India having 1/6 of the world population, India representation of South Asia in world cohorts is very, very poor. So in this study, we extracted the data from the juvenile SLE cohort, inception cohort from India, which has been taken from 10 institutes, and we have defined juvenile onset lupus as less than 18 years. As we know till now, lupus is thought to be more severe in juvenile population. We went through the Indian SLE inception cohort for research database and extracted data on juvenile SLE with the age of presentation less than 18 years and adult SLE with age of presentation more than 18 years. We extracted the demographic data, clinical features and autoantibodies. We analyzed them with statistical methods. We compared juvenile SLE with adult SLE, as well as we compared the juvenile SLE with other cohorts across the world. The study has been started from 2018, and till date there have been 2033 lupus patients who have been enrolled, of which 14% are children and 86% are adults. Of the children, the juvenile SLE patients, majority of them are between 15 to 17 years, and only one of them was less than 5 years. Coming to the comparison between adult and children, the female is to male ratio in adults is similar to world cohorts, around 12.5, and in children it is 8.5. The mean age of the participants was 29 years, and in children it was 14.7 years. Children had a more severe disease compared to adults. Coming to the clinical features, children had higher incidence, higher mucocutaneous features, alopecia, fever, as well as autoimmune hemolytic anemia, more neuropsychiatric manifestations, and more renal involvement, compared to adults who had more arthritis and immune cytopenias. Coming to the comparison of juvenile SLE across the various cohorts compared to other countries, Indian cohort had more mucocutaneous features, more oral ulcers, and rest of the manifestations were similar. Smith antibody had higher representation in the Indian cohort. As compared to adults, children presented early had more fever, oral ulcers, rash, autoimmune hemolytic anemia, pericarditis, seizure, and less female bias, lesser cytopenias. This is very similar to the data in previous studies done from our previous retrospective study done from our country, and it is very similar to those seen in the other countries. When we compared the data of the juvenile lupus with the other worldwide cohorts, they had higher disease activity. This was probably linked to the longer duration of symptoms compared to the Cara inception cohort, and it is known that Asians have more severe disease. Fever and oral ulcers were more common, and this is due to the higher fever and oral ulcers were more common in this population, and there was higher prevalence of Smith antibodies. This might be related to the difference in the genetics. With longer longitudinal follow-up of these patients, will be able to answer these questions in more depth. Thank you.
Thank you very much. Now, upper is open for discussion.
Yeah, thank you very much. Most of your patients you identified as in the adolescent age group, and you did mention there were some less than 5 years old. Did I catch that?
There was one patient who was less.
Only one. Okay, did this patient manifest with more severe symptoms?
Yes, sir. This patient manifested more
compared
symptoms.
to the adolescent group.
Yes, sir. This patient manifested more symptoms. At the onset, the patient had neuropsychiatric as well as nephritis as a manifestation, with oral ulcers and the fever being the presentation with which the patient presented.
Okay, and your cutoff from pediatric to adult is in your country is it 18 when they turn 18?
Yes, sir.
When they turn 18.
Yes.
Okay, thank you.
Not much to ask. Anti-Smith antibody were high, you told us.
Yes.
What was the, data for that? What was the percentage or something like that? Did you show it to us? How much it was, more than the adult group?
Yes, sir.
Was it significant?
It was
Statistically?
significant, sir. I had mentioned. I did
Okay,
not
okay.
explicitly mention the this,
Okay,
but it was
okay.
mentioned in the slides.
Okay. Thank you. I don't have to ask.
Compared to the other country studies, the neurological symptoms in India was higher. You showed that 14.5%.
Yes, sir.
You didn't mention it in the summary.
Yes, it didn't achieve statistical significance.
Compared to the other countries, it is 2% or 3%, but it is in 15% is little.
Yes, sir.
Is it an ongoing work or?
It's an ongoing work. It was a 5-year inception cohort. Now the recruitment has been completed. They will be followed up for longitudinal.
Thank you very much.
Thank you.
I think this brings us to the end of the session, and on behalf of my co-chair, Dr. Molly, and myself, I would like to thank the judges, Dr. Lorenzo from Philippines, General Bakuni, all the attendees, and especially Dr. Dhanda, who made it convenient to come in the morning. Thank you very much. This session is now closed.
Rheumatologist, we deal with osteoporosis quite frequently, and especially those who are on glucocorticoids, we have to assess the risk for osteoporosis periodically. And usually the severity can range from simple osteopenia to complicated osteoporosis with fragility fractures. And sometimes a subset of patients can be like they respond poorly to treatment, making the management more challenging. So here we have an opportunity to learn from the experts and review our knowledge on the subject. So with this, I invite the chairperson for this session, respected Dr. D.S. Bakuni, onto the dais. Sir, Dr. D.S. Bhakuni is a consultant rheumatologist from Manipal Hospital, Dwarka. So I request the respected chairperson to start the session. Thank you.
Thank you, Dr. Nikhila. May I call upon Dr. S. Vidya Srinivasan for the talk, please. Everyday practice, bone health in women.
Good morning, sir. And in the next 14 to 15 minutes, I will be talking about the basic pathophysiology of osteoporosis in women. And I would also be throwing light on the on whom to screen, when to screen, and therapeutic modalities that are available already. And I would also like to throw light on the newer insights in pathophysiology of postmenopausal osteoporosis and the targets for future treatment. So basically, osteoporosis affects 1 in 3 women in the West, and in India the prevalence varies between 25 to 62% in various studies. And obviously, aging of the population worldwide is responsible for a major increase in the incidence of osteoporosis. And in females, the peak bone mass is achieved in mid-20s. It remains relatively stable thereafter until the beginning of menopause, whereupon a rapid period of bone loss ensues. And as you see, in the panel to your right, even if there are no obvious clinical fractures, there are at least radiographic vertebral fractures in women as the age advances. And apart from the conventional risk factors like increasing age, sex, low body weight, and what are the other primary causes of osteoporosis? Previous fragility fracture, particularly of hip, wrist, spine, and vertebrae. And there is a parental history of hip fracture, glucocorticoid treatment by mouth for more than 3 months, current smoker, and alcohol status of more than 3 drinks per day. And the other secondary causes include rheumatoid arthritis, untreated hypogonadism, both men and women, inflammatory bowel disease, prolonged immobility, organ transplantation, type 1 diabetes, endocrine disorders, and chronic obstructive pulmonary disease. And this diagram tells us the central role of estrogen in maintaining bone homeostasis. So as early as in 1980s and 90s, we knew about the crosstalk between estrogen and immunity. And estrogen controls the T-rex cells which inhibit osteoclastogenesis. And this crosstalk between immunity and osteoporosis is now given the term immunoporosis. And as the years passed, as early as 2000s and the second decade of 20th century, we came to know that FSH is actually opposite to the estrogen role in immunity. It actually stimulates osteoclastogenesis and inhibits osteoblastogenesis. And whenever there is an increase in adipogenesis or osteoclastogenesis and osteoblastogenesis is less than the other two processes, the net result is osteoporosis. So when you look at the aging and the estrogen deficient state, you see there is an increase in pro-inflammatory cytokines like TNF alpha, 6, 17, 23 and TGF beta. Normally, the bone marrow mesenchymal stem cells develop into osteoblast through a pathway of pre-osteoblast and final osteoblast, whereas the hematopoietic stem cells through a pathway of monocyte and pre-osteoclast develop into full-blown osteoclasts. And this whole process is facilitated by WNT signaling, and LRP5, lipoprotein receptor related protein 5, is a cofactor in WNT signaling along with beta-catenin. And under the influence of estrogen, androgen and calcitonin, this pathway progresses to the formation of osteoblast. And parathormone inhibits this pathway by stimulating sclerostin, which is a blocker of WNT signaling. And calcium and vitamin D aid in this pathway by stimulating growth hormone and insulin-like growth factor. But when you look at the left-hand side panel of the diagram, you see the immune cells under the influence of pro-inflammatory cytokines brought on by aging and estrogen deficiency develop into adipocytes. And they can also go through this pathway. And estrogen inhibits this process. It also secretes, makes the osteoblast secrete osteoprotogrin, which is a decoy receptor for RANKL and RANK binding. And this pathway is inhibited under the influence of estrogen, androgen and calcitonin. So, and this is the central role that estrogen plays, and whenever there is estrogen deficiency as the woman ages, the whole system collapses. And what is the role of memory B lymphocytes here? So there is also a reduction of B lymphocyte number in osteoporotic women, and this reduction negatively correlates with BMD, and that's the reason why there is an increased morbidity and mortality observed after an osteoporotic fracture. Because of this B cell defect, the woman has an increased susceptibility to infections too. And I'm just trying to throw new insights into the pathophysiology of postmenopausal osteoporosis. And as you see, an elderly woman is obese. There is more of adipogenesis and less of osteoblastogenesis. And autophagy has been found to have a new role in the process of aging and osteoporosis. And depending upon the type of cell involved, the role of autophagy varies. In osteoblasts, autophagy induction is actually beneficial for the growth of osteoblasts. And autophagy is the process which removes the bone marrow mesenchymal stem cells which are senescent from the circulation. Whereas in osteoclasts, the autophagy induction leads to proliferation of osteoclasts and its survival. So whenever there is aging, there is inhibition of autophagy. This leads to increase in the expression of P53 and reactive oxygen species contributed by iron overload. So all this lead to bone marrow mesenchymal stem cell senescence. There is more of adipogenesis and less of osteoblastogenesis. And we will also look at the role of gut microbiome now. There are new insights coming up. And this also depends upon the type of gut microbiome that we have got. So usually the gut bacteria facilitate the digestion of carbohydrates and produces short chain fatty acids like butyrate, and this is found to have an important effect on the microbiome regulated bone marrow formation. At the same time, presence of segmented filamentous bacteria facilitates the catabolic effect of parathormone on the bone tissue. This induces a pro-inflammatory cytokine milieu like producing more of T helper 17 cell population and TNF positive T cell contributing to osteoporosis. So this was what I was talking about. So in monocytes, which is a precursor for osteoclast, if there is a selective deletion of autophagy gene 7, this reduced the extent of osteoclastic differentiation and bone loss induced by ovariectomy. This is in animal mouse models. This is akin to postmenopausal state. Richter is another target, and this is essential for the formation of osteoclast, and Richter ablation can reduce the osteoclast number and improve bone mass. And again, another new insight coming up in postmenopausal osteoporosis is the presence of this long non-coding RNA, PAX8AS1, and this is found to be upregulated in the proximal tibial region of rats which have undergone ovariectomy, whereas the silencing of this gene is shown to attenuate osteoporosis. So all these are newer insights coming up in postmenopausal osteoporosis. So coming to iron homeostasis, both iron overload and iron deficiency can contribute to osteoporosis, and by its direct effect on the bone metabolism or its role as a concomitant factor of the endocrine system. So excessive iron leads to reactive oxygen species and pro-inflammatory cytokine milieu, whereas again in iron deficiency anemia patients with osteoporosis, the osteoporosis was higher. So this was evidenced by treatment of iron deficiency anemia with repeated blood transfusions. This reduced the risk of osteoporosis. So iron plays a very important role in osteoporosis too. So coming to the assessment, so it is usually diagnosed when an X-ray shows a sign of demineralization or there is evidence of compression fracture. So as it is insensitive, we have other techniques like DEXA and quantitative CT. And we can also look at bone turnover markers. We have the resorptive marker, which is the C-terminal telopeptide of type 1 collagen, and the N-terminal propeptide acts as a formation marker. So coming to whom to screen, I am not talking about National Osteoporosis Foundation guidelines here, because the first 4 criteria was for screening parameters a part of NOF here. So whom to screen? All women aged 65 years and older, irrespective of the risk factor, and any woman between 50 to 70 years whenever a risk factor is present. Any adult with a fragility fracture or any condition which warrants medication associated with low bone mass, anyone being considered for pharmacologic therapy who is being treated for osteoporosis to monitor, anyone not receiving therapy also when the evidence would lead to treatment, and women in the transition phase whenever there is a specific risk factor, and any postmenopausal woman who plans to discontinue hormone replacement therapy. And we use the 1/3 radius site in patients whom hip or spine cannot be interpreted, or the patient is morbidly obese, which outweighs the limit of a DEXA table. So FRAX score, this is for want of time we will not go into the details, and this calculates the 10-year fracture risk, and it is more accurate when used in untreated patients. So those who are already on treatment, it may not be accurate, and this is freely downloadable online. So apart from the WHO conventional criteria for classification, the 2020 American Association of Clinical Endocrinology diagnosis states, regardless of the BMD, any low trauma spine or hip fracture, or if the T-score is in the osteopenic range, whenever there is a fragility fracture or there is a high fracture. These are the patients who would be diagnosed with osteoporosis. So when to treat? So you look at the clinical risk factors, you either apply FRAX or you apply BMD, and if it is low, obviously we are not going to treat. If it is high, we are going to treat. In the intermediate group, if you have used FRAX, we can reassess with FRAX and BMD and decide upon treatment. If we have used BMD, we can apply the FRAX score and decide upon treatment. And obviously the thresholds are country specific. In a country like ours where there is a high incidence, we need to have a low threshold. Coming to management, so apart from lifestyle modification, we can use either anti-catabolic or anabolic therapy. So this is just a summary of all the drugs that we already know. Here I would like to concentrate only upon this cathepsin K inhibitor, which is newly coming up, but it is still unapproved for use. And this there is no interference with bone formation. It restrains the activity of cathepsin and limits absorption. So, and we have lots of side effects for each coming up. Stroke and atrial fibrillation are common side effects of cathepsin K. And one more thing, the newer uncoupler strontium renalate is a dual acting agent which inhibits both bone formation and absorption. And the traditional Chinese medicines, meaning they talk about flavonoids, so which are actually estrogen rich, and they inhibit bone mass loss through regulating the osteoblastic activity, and they enhance bone formation through promoting osteoblastogenesis. So all can be used for in the treatment of postmenopausal osteoporosis. So it is obvious that the third generation biphosphonates have almost 1,000 to 10,000 times more potency than the first generation. So this is the treatment algorithm, 2020 postmenopausal treatment algorithm as proposed by AACE. And you look for secondary causes of osteoporosis, and if there is apart from conventional lifestyle modification measures, correction of vitamin D, so if there is a high risk and no prior fracture, we can use alendronate, denosumab, risedronate or zoledronate. Alternate therapies include raloxifene, and we have to reassess yearly for response to therapy. If there is an increasing BMD or stable BMD and there is no fracture, we can consider a drug holiday, which is about 3 years for an injectable bisphosphonate and 5 years for an oral, after 5 years for an oral therapy. And whenever the BMD declines beyond the threshold level or bone turnover markers rise up to the pre-treatment level, we can restart treatment. And always keep looking out for secondary causes. If the patient is using an oral agent, we can switch to injectable antiresorptive. If the patient is already on an injectable antiresorptive, we can switch over to abaloparatide, romosozumab or teriparatide. And this is with respect to a person who has got a high risk but no prior fracture. Very high risk with an obvious prior fracture. So we directly go to abaloparatide, denosumab or romosozumab. And alternate therapy only includes alendronate and risedronate. So similarly, we'll have to reassess yearly for response for the therapy and fracture risk, and we can change over. And bezidoxifene, we all of us know about raloxifene and tamoxifen. So this is a third generation stem, still more highly selective, prevents osteoporotic fracture with more tissue selectivity, and can be used for patients with fractures in RA2. And abaloparatide is an anabolic agent that increases BMD, reduces risk of both vertebral and non-vertebral fractures. So coming to romosozumab, this is a human IgG2. This binds to sclerostin. It's an anti-sclerostin antibody and blocks osteosclerosis. And the active controlled fracture study compared alendronate with romosozumab, and this resulted in significantly greater improvement in bone mass and parameters pertaining to bone strength. Again, another study comparing denosumab and romosozumab in postmenopausal OP showed romosozumab was found to be superior to denosumab in the treatment. So coming to the role of gut microbiome, role of probiotics in treatment. So I would just finish, sir. So probiotics actually alter the inflammatory cytokine milieu present in the gut. They actually inhibit the population of T helper 17 cells, thereby decreasing the cytokines IL-17, 6 and TNF alpha. At the same time, they also stimulate Treg cells, promoting osteoblastogenic cytokines like 10, 4 and interferon gamma. And they also stimulate bone morphogenetic protein 2 and SPARC. So this pathway leads to osteoblastogenesis, and the inhibition of this pathway leads to improvement of bone mass. Also, they alter the intestinal epithelium and secretion of TNF positive T cells and T helper 17 population. So future directions include alpha ketoglutarate, which is an intermediate of Krebs cycle. This is also used in the maintenance and metabolic functions of the bone. So we have seen about cathepsin K inhibitor, senolytics. So these remove the senescent bone marrow mesenchymal stem cells from the circulation. So we have dasatinib and quercetin coming up, and these inhibit bone resorption. Hydrogen sulfide, actually the incidence of increased hydrogen sulfide was greater among OP patients. So this alters the microbial community of the gut, and these can be, one interesting finding is the oral garlic, which is a source of diallyl disulfide donor, DADS it is called. So this is part of Chinese medicine and herbs which improves osteoporosis in animal mouse models. So monitoring follow-up, so very important to decide the frequency. If markers are available, they can be monitored once in 6 months. DEXA scan once in 1 to 2 years, and X-ray if it is clinically indicated. Always look for atypical femoral fractures or osteonecrosis of the jaw. Drug holiday we have already talked about. Thank you for your patience with me. Thank you.
Thank you, Dr. Nikhila. Sorry, Dr. Vidya, sorry. Thank you very much. After the turn of women, the male always comes second. So the next topic is male osteoporosis. May I call upon Dr. Kaushik Basu? Initially we are thinking whether the hall will be full or not, but the hall is full. You can see your left or right, hall is full of vacant chairs. So don't worry, we are already full. Please go on.
Thank you, sir, and respected dignitaries. I thank the organizers for raising the topic of male osteoporosis, less talked upon. And in the next 15 minutes, we would be covering up why should we discuss, how and why it is different from the postmenopausal, diagnosis, diagnostic tools, which Dr. Vidya has covered up some, so I'll skip some slides. What to look for in the male osteoporotic patient and treatment. The sheer number should prompt us to look for male osteoporosis. 1 in 5 men above 50 will undergo fracture in their lifetime, which is evidence-based, and there would be 540 million above 50 years in India in about 2050. So about 100 million people at risk. So we cannot undermine that. This important study from the Dabo Osteoporosis Epidemiology Study Group pinpointed another reason why we should study male osteoporosis more. If we would see carefully that in the Kaplan-Meier survival curve, each 1 in 2 male patients who are suffering from hip fracture would not live more than 1 year. So that is so serious. In women, the risk is more, but it is not as much as in men. So men may suffer from fracture less, but the mortality and morbidity is more. The difference is mainly that the women lose more bone post-menopausal, but in the men, the loss is gradual and continuous. And hence, we see a spurt in fracture in women from 72 onwards, so 70 years onwards, but the spurt in fracture in men is above 80. So men have 10 years more, but the fracture incidence nearly equalizes at that age. Why is it different? About 8 to 14% of more bone mass. Men attain peak bone mass later than women. Despite comparable body size, male have greater bone mineral content and bone mineral density than females at hip and distal tibia, but not at spine. Thickness of cortex and total bone width are primary determinants of bone strength, which are more in men. Estimated annual bone loss is more or less similar, but exception is that the men who smoked at baseline were more likely to lose BMD at the hip. This study undermined that men are less screened for, and among the DEXAs ordered, only 15% were men, but the osteoporosis and osteopenia were comparable. And surprisingly, more surprisingly, it was seen that men were less treated even with calcium and vitamin D compared to women. So there is serious gender bias. Diagnosis, Dr. Vidya has covered up. Fragility fractures whenever should be picked up. BMD is the standard tool because of the robust data that it has provided over 15 years with various studies. Trabecular bone score is available in the newer BMD machines. It is a Grayskull software derived score where we have the idea of the provides information about the underlying bone independent of the BMD. The BMD actually accounts for 70 to 80% of the bone strength. The rest is unknown. So trabecular bone score adds to that, and in a meta-analysis of about 18,000 men and women, it was seen that TBS predicts hip and major osteoporotic fracture risk in men as well as women independent of fracture probability of FRAX. But we have to use the version 2.1 where the male data is included. The other modalities could be QCT, but it is more expensive, less reproducible, and has higher radiation risk. Quantitative USG it could be good, but the WHO criteria doesn't include that. And peripheral DEXA has problem with technical differences and lack of standardized reference, though it is a small machine and can be used at other peripheral places to screen. I'll skip this. Dr. Vidya has already said. Only thing that I will point out is that the ISCD in 2019 position states that even in men above 50, we should use the uniform Caucasian female reference for reporting the T-score. And in males younger than 50, we should not at all utter the term T-score. Rather, the age-matched, ethnicity-matched Z-score should be used. Indications for testing: men 70 or older or less than 70 with low body weight, prior fracture, high-risk medication use like glucocorticoid that we use often, or any disease or condition like COPD that is associated with more bone loss, and do not miss loss of height of more than 1.5 inch. This is the fracture risk, the FRAX tool, where it can be taken for our country. It is available in English as well as in Bengali, not yet available in Hindi. It takes the BMI, male or female, and takes the risk factors such as previous fracture, genetic components in the form of parent fractured hip, current smoking, alcohol more than 3 units, secondary osteoporosis where there is known, glucocorticoids, and rheumatoid. Now one factor is that we know that other CTDs and angstpon have also tendency to lose bone, so we can use in patients of lupus or angstpon, we can use this parameter in FRAX, though it is not mentioned. But there are studies with that. FRAX has some limitations where it may underestimate fracture probability in individuals with multiple or recent fracture, high-dose glucocorticoid exposure, diabetes mellitus, and parental history of non-hip fragility fracture. Garvan Institute has developed another score where 2 of these factors have been taken into account, right? Fractures since the age of 50 and falls over the last 12 months. Suppose a patient falls thrice in the last 12 months, the Garvan Institute score, which predict much better fracture risk than the FRAX score. But suppose in a patient who is on corticosteroid, is diabetic, and is a smoker with multiple clinical risk factors, the FRAX score would be better. So both complement each other, use wherever applicable. Now we have a patient diagnosed of male osteoporosis. What to look for? About 5 to 20% of these male patients, aged male patients, would have hypogonadism. Vitamin D deficiency, the pandemic is still going on, so it has to be checked. Malabsorption, inflammatory bowel disease is may be present subtly, and important for us rheumatologists are smoking, alcohol, glucocorticoid use, whether the patient is suffering from rheumatoid, CTD or Angstrom, or the patient is immobilized due to pain, or the patient is using PPI, anticoagulants or other drugs that may cause excessive bone loss. Now, in several studies it has been seen that aged male with osteoporosis have hypogonadism, the prevalence between 2 to 18%. So that should be checked, and if present, please consult a endocrinologist for treatment, because once treated, the effect is quite good. Those with hypogonadism have increased bone mineral density with testosterone alone. Glucocorticoid-induced osteoporosis is best prevented, so lowest possible dose, less duration, and use calcium and vitamin D liberally. And wherever the treatment or prophylaxis is needed, bisphosphonates score over others with sheer data that we have, the number in men. So who do we select for treatment? Those who have already hip or vertebral fractures without major trauma, and the osteoporotic ones. Those osteopenic with fracture risk above 20 or hip fracture risk more than 3% or receiving long-term glucocorticoids should be selected for treatment. Treatment would comprise of non-pharmacologic measures like weight-bearing exercise, prevention of falls, calcium, vitamin D should be given liberally, and loading vitamin D helps only for those who are deficient, not all. Treatment of the underlying cause is most important. Bisphosphonates have been particularly studied in men, and it has been seen that bisphosphonates prevent vertebral fractures significantly and non-vertebral fractures just significantly, and among them alendronate and risendronate are the agents to be used, because zolindronate closely miss the significance mark. Teriparatide, yes, teriparatide does work well, and it is usually generally reserved for men with severe osteoporosis with low BMD score of less than -2.5 and at least one fragility fracture, and who have failed previous therapy, and it has a cap of using more than 1.5 to 2 years. It had a cap, but it increases the bone mineral content at least by 6% every year. Recently, this study was published that teriparatide did not increase adult osteosarcoma incidence in a 15-year US post-marketing surveillance that has led to the US FDA taking back and removing the 2-year lifetime treatment limitation and box warning about teriparatide. So most probably in future teriparatide could be used more than 2 years. Denosumab definitely increases BMD in men, has been studied separately, and specially useful in special conditions like impaired renal function where it is difficult to use bisphosphonate. But there are problems with denosumab and teriparatide in terms of that when we stop them, the bone mineral content decreases in the next 1 year, and there might be multiple rebound vertebral fracture, particularly seen in denosumab. So when we are planning teriparatide or denosumab, we should simultaneously sit with the patient and plan the exit therapy. What are we going to do when we stop denosumab and teriparatide? That has to be planned at the start. And while you read on the summary, I'll tell you a story about my friend's dad. He had an osteoporotic fracture. He had a fracture in 2017. So my friend who resides in US sent him to me, and I walked up, and he was seen to be osteoporotic. Started on a bisphosphonate. 1 year later, he had another fracture. So I was thinking what to do, and his son called me up, and we started teriparatide for another. Planned for another year. In between, he had another fracture, and his son came back to India, and while talking, just informed me that his dad has become slow. So he was ultimately worked up. He had Parkinsonism, which has increased propensity to fall. And there were two things other that after my friend came, I went to his house and seen that he had divided in between the rooms. That is very much prominent in old Indian homes. And between the way from bed to the toilet, there was no light. So these two things were changed. I asked him to do. And till 2018, till 2022, he did not have any more fracture with the same therapy. So small things add up to great effects. That is the crux of my talk. Thank you. This is my institute. And the sad dog in my first slide has become happy after they have found the answer.
Thank you, Dr. Kaushik. Now the house is open for the question answer. Yeah, anyone? Or everyone has learned everything? Yeah, sir. Sir.
Important thing.
Okay.
Actually, when we treat any person with osteoporosis, especially elderly people, the first thing is remove all the carpets of their house. Here's number one. Number two, either the doormat has to be of rubber which doesn't crumble, or any soft cloth door strap should be removed. Number three, bathroom going at night many times is very common in old age, so you must have adequate light on
correct.
the way and in the bathroom. Number four, you must have some hand support when you get up from the pot.
Absolutely right, sir.
Especially the sleep as well. I think these are most important. Drug is important. Vitamin D, calcium, physical exercises, losing weight and having plenty of milk and eat vegetable. Everybody knows it. But these small things matter the most important. I think night and the removal of a carpet. Because in my clinical experience of more than 50 years, I think they were the two most important things which make you fall. So when you get old, especially like us, you have to be very careful. At the same time, when you get from the bed, you have postural fall. So you feel a little giddy. So wait for some time on the side of the bed, continue sitting it, take 2-3 deep breaths and make little exercise of a hand and leg, and then get up and go to the toilet. Grabbing that helps.
Thank you very much, sir. This is coming from a senior citizen who himself is a doctor and who himself practices rheumatology. These are the pearl of wisdom, I can say. You must follow this. Yeah, Meha, Dr. Meha.
Seconds, sir. Wonderful talk. I wanted to know whether there are studies of combination therapy in men, because we have some combination therapy studies in females.
No.
Combining the PTH analogs and anti-resorptive.
There has been reports of synergistic effect with teriparatide and denosumab in women, but I have not included because there has been none with men, specifically men.
Fair enough. Thank you so much.
Yeah, any other question, please? Yeah, Dr. Arup Kundu.
No question. Really brilliant talks by the two speakers. One thing I must admit as comment, that this is where internal medicine comes. We have to read the causes of falls in the aged. There are at least 25 to 30 causes. Sarah's told 4 to 5. I have seen one patient has got a big step to attain the commode. So there are so many things. So one has to read these causes of fall in the aged must be associated with this treatment of osteoporosis.
Thank you, sir. I think it is time for us to maybe send some paramedics to the house of the patients with osteoporosis and falls.
The gist is night light should be there, no fall should be there. Yeah, doctor.
After discontinuing teriparatide or denosumab, the bone mineral density comes down after some time. So how to switch over to another agent and when to switch over?
The exit therapy is actually given in the guidelines. Within 3 months of stopping teriparatide or denosumab, start a bisphosphonate, which can be continued to 3 to 5 years. And once you start bisphosphonate, that bone mineral content will be held on because it's primarily anti-resorptive.
Correct. Any other question from the house, please? If there are none, then I'll again thank you, Dr. Kaushik, for the nice session. Now I call upon Dr. Meha Sharma. When should we treat osteopenia? Because it's very easy to treat osteoporosis. What I mean to say that the moment you say word osteoporosis, that means the patient requires treatment. But the dilemma exists when there is osteopenia. What are the practice dilemma? And for discussing that, Dr. Meha Sharma is here.
Very good morning. I hope everyone is having a wonderful time at Indore. So we have had a very wonderful talks on osteoporosis. Now let's talk about the less discussed and less talked topic, that is when to treat osteopenia. So we'll be going through the topic. First of all, I'll be defining the problem and what are the real world data available on osteopenia and the current guidelines, what they have to say about osteopenia. But more importantly, we are going to focus on what are we missing while we are not talking of osteopenia and while we are not making an early diagnosis and treatment of osteopenia, and what are we finally going to achieve if we decide to treat it. Now this has been covered very nicely in the previous presentations. I'm not going into the definition, but we all know that by the current criteria, we define osteopenia as a T-score of between -1 and less than -2.5. Now though we have been focusing a lot on the T-score values in the BMD, now the changing perspective is that just focusing on the T-score might not be good enough. So we need to focus more on the increased fracture risk, that are the more important clinical implications of having a low bone mass. Now talking of the burden, Indian patients are actually more prone to have osteoporosis and osteopenia, and it is obviously attributed to the genetic differences that we have from our Western counterparts, the nutritional deficiency and the smaller BMIs. The overall incidence in India is around 52% for osteopenia and around 18 to 20% for osteoporosis, which was beautifully seen in this large study, which included around 31,000 patients in India. Now coming over to the real world data, but before that, why do we need to screen? As we can see, it is a major healthcare burden, and it not only increases the morbidity and the mortality, but it also poses a significant economic burden on the society. So this is a study from South Korea, which calculated the 10-year fracture risk in postmenopausal females, and it was shown, as we can also predict, that the fracture risk is significantly higher in osteopenic and osteoporotic patients as compared to females who have normal BMDs. Now this graph shows us that an 80-year-old female will have 5 times increased risk of fracture than a 50-year-old postmenopausal female with the same T-score value. The point which I want to make here is that age is an independent risk factor for fracture, even with the same bone mineral density T-score value. Also, for every standard deviation fall in the T-score that we have, the fracture risk increases by 2-fold. Now, we all know, and we have gone through these slides in Dr. Vidya's presentation, whom to screen. The criteria has been given by the National Osteoporotic Foundation. Now, for Indian patients, what is important for us to know is that because the prevalence is high, the ISBMR has recommended that we need to screen them a little earlier than the Western counterparts, and that is 60 and 65 years for females and males. We all know the modalities for whatever flaws that DEXA has, it still remains the gold standard of screening. Now, what are we missing while we are not picking on the osteopenia patients? What we are missing is that fracture is multifactorial. It is not only the T-score, and BMDs might not be optimal enough. And in fact, there was a study conducted by World Health Organization which stated that osteoporotic fractures can occur at any given T-score value, even a normal T-score value. In fact, a large study of 2,300 patients, postmenopausal fracture patients actually, 82% actually did not fulfill the criteria of osteoporosis and were osteopenic instead. The probability of fracture in an osteopenic female will be 26% even with a single risk factor apart from the T-score that I am talking about, vis-a-vis a patient who has no risk factor at all. So how do we know that which patients are at risk of having fractures? For that, we need to know what are the secondary causes of bone mass loss, and that also has been actually covered, but broadly it is categorized into endocrine causes, nutritional causes, drugs, and other causes. Endocrine causes, the noteworthy are hyperparathyroidism, hypothyroidism, hypogonadism. or malabsorption syndromes and chronic malnutrition. Drugs, obviously glucocorticoids are the most important ones for us, but in fact aromatase inhibitors, anti-epileptics are noteworthy. And in other causes, of course, what we are more interested in, chronic inflammatory diseases like rheumatoid arthritis, metabolic diseases like chronic kidney disease, and hematological disorders like myeloma. So now this is also another beautiful depiction that with the same T-score value, the risk will be different for the every different risk factor that you have for fracture. So prior fracture, glucocorticoid use and family history will significantly increase the risk. The best fracture risk assessment tool that we have as of now is PRAX, and it covers 12 parameters including the age, sex, weight and previous fracture in the patient itself or a parenteral hip fracture. Glucocorticoid use, current smoking, alcohol intake, which they have beautifully defined also, and rheumatoid arthritis and secondary causes also they have defined in the FRAX score actually. So now these are the definitions. Basically we all know that corticosteroid use, the minimum should be 5 milligram prednisolone or equivalent for more than 3 months. They have defined what 3 units of alcohol would mean, obviously depending on the type of alcohol you are taking, and secondary osteoporosis, what are the diseases we are covering. Now this is a tool that gives us a 10-year fracture risk for hip and major osteoporotic fracture. Major osteoporotic fracture means at the wrist, at the forearm, at the proximal humerus and spine. Anything that is more than 3% hip fracture risk or 20% major osteoporotic fracture needs treatment. Now we have some limitations of FRAX as well. Because hip fractures are more reported and spine fractures are mostly silent and not reported, so we may not be having an accurate picture of the other fractures than the hip. Obviously it is not validated at hip and total femur BMD because we are considering the BMD at the neck femur only. It is not validated yet for patients who are less than 40 and more than 90 years of age. What they have not included is the history of falls, which is included in the other score that we were talking about in Dr. Basu's presentation. But for that, we only have 6 parameters, whereas the FRAX covers 12 parameters. Bone turnover markers, in fact, there have been a lot of studies that bone turnover markers can tell us about the risk of having fracture, are not covered in FRAX score, and so is not covered what is the lifestyle of the patient and the vitamin D levels and other things. Obviously, it is not validated for patients who are osteoporotic already and on treatment. So out of all the studies that I am going to tell, the most clinically relevant study is actually this one, which was, it was a 6-year prospective study in which they divided the patients into 2 groups, one receiving only placebo and the other receiving 4 monthly zoledronate infusions. There was a significant reduction in the number of fractures in the group that was receiving zoledronate. And there were 190 fractures in the placebo group and only 122 fractures in the zoledronate group. But the number of patients that we need to treat to prevent fracture in one woman was 15. So, but this was the most clinically relevant, which can be, in real world scenarios when we treat a patient, we need to know what would be the cost effectiveness and how many patients treatment would actually prevent a fracture. Rest all the studies, there have been studies in thalassaemic osteopenic patients, in Crohn's disease osteopenic patients, in male osteopenic patients, in postmenopausal females who were giving SERMs. All of these studies have actually only shown, but significantly shown, reduction in the bone turnover markers, number 1, and increase in the bone mineral density. But what they have not shown is what was the extrapolation of the data or what were the clinical implications. Were we actually able to reduce the number of fractures has not been shown in a lot of studies. So the first study was the most important one. This is again in Japanese men, in Chinese postmenopausal females, and now what I am interested in telling via this presentation is how do we deal with these patients, because we don't have any clear-cut guidelines. So how do we deal and decide on day-to-day basis? These are the few hypothetical case scenarios. So number one, a 26-year-old male comes to us with a tibial fracture in a road traffic accident. He's a smoker. He's an alcoholic. He takes around 60 ml of alcohol per day. But he's not on any chronic medication, illness, or any previous fracture. He does not give any history of previous fracture. So his T-score at hip is minus 1.9. Whether would you like to treat this patient or not? I would invite 1 or 2 comments from the audience. Can you give me a reason why? Correct, correct. So we need to know what kind of fracture the patient had, what T-score value we are looking. Of course, the risk factors are very important. The risk of having fractures. Now he is an alcoholic, but the amount is actually not that much. Obviously, if we see, it is only around 2 units of alcohol, but he does not give any history of low trauma fracture in past as well. Sorry. He is a smoker, though that is a risk factor, but he is a very, very low risk patient. The next 3 patients, as you can see and I have underlined, the risk fractures are significant. Any patient with osteopenia with at least 2 other risk factors and an age which again becomes an independent risk factor would warrant treatment. So a 46-year-old, but she is a premenopausal female, she is having SLE and is on 5 mg of prednisolone for a year, number 1 risk factor. Number 2, premature ovarian failure, which occurred at 38 years of age. Though does not give any history of fracture, she's definitely high risk, and she has a T-score of only minus 1.4, but she's high risk. Case 3 and 4 again are high risk. Third one is 52 years. She's postmenopausal. Postmenopausal state in itself is a risk factor. She's smoker. She's an aromatase inhibitor for 7 years. So once you have 2 or more risk factors with an osteopenic T-score value, you should consider treating this patient because the fracture risk will be higher. Obviously, I cannot decide that, okay, this risk factor is more important or more significant. I definitely would like to go for a frac score or a quantitative estimation of how much will be the risk for these patients. Again, the last case, 62-year-old male with hypogonadism. He's a smoker. He already has 2 risk factors. Though he's only 62 years and usually the screening age for men is 70 years as of NOF, but in India it is 65 years. But still, and he has a significant T-score of minus 2.1 at spine. So my take-home message basically for this presentation is that obviously after realizing the burden of the disease, osteopenia is actually majority and much more prevalent than osteoporosis. The key to diagnosing osteopenia or treating or deciding to treat whether we want to treat these patients or not is fracture risk assessment. The best tool available at this point in time is FRAC score. We need to have a very low threshold for calculating FRAC score in our day-to-day practice in clinic. Obviously, we have to individualize treatment. I'm not going into the what treatments we can give these patients because that would remain the same as that for osteoporosis. And we need a lot of clinical studies to see whether the reduction in BMD or improvement in bone mineral turnover markers that we are seeing in the studies that we have available is extrapolating or is correlating with clinical fracture risk or number of fractures reduction. Thank you.
Thank you, Doctor. Thank you, Dr. Meha. Now I am supposed to give you some practical tips. Thank you. How is this? Same slide. 5 slides. Initially, I thought that the house is full of credit shares, but I think now the glass is half full of half empty. Am I audible? Yeah. So when should we treat osteopenia? The practice tips. As I've been retired from the army now, I'm a private practitioner, or you can say that practitioner. So I'm supposed to give you tips. So what are those tips basically? The issues regarding treating osteopenia. As I told you, the moment you hear the word osteoporosis, that means you have to treat. But the moment you hear the word osteopenia, you have to put your brain whether we should treat them or not. Why? Because there are issues in treating osteopenia. What are those issues? Because the diagnosis is based on DEXA scan and most of the patients are asymptomatic. So it's difficult to make the diagnosis initially. However, we must be very serious to deal with these patients because the patient of osteopenia, they are predisposed to low impact and pathological fractures of all these vertebrae, hips, wrists, metatarsal ribs. You must have heard that ladies beyond 55 or 60 years, when they are playing with their grandchildren, they come with a pain in the ribs. Initially they will go to their private practitioners and GPs. They may miss this, but as a rheumatologist, we should not miss it. They are pathological fracture or fracture with fragility. With a trivial trauma also, the patient of osteopenia can get a fracture. That's how the importance. In one of the studies where I could lay my hands on, Dr. Neelam Kaushal, she published her studies for the burden of osteopenia in our population. She took around 854 patients and this study was published in 2018. It showed that 34% of the population was osteopenic, and out of this 34%, 40% were females, those were post-menopausal. So the moment we know that the patient has come of osteopenia, we must find the secondary causes by doing simple investigations of biochemical parameters. If in these biochemical parameters, if you find low calcium, then please rule out parathyroid hormone disorders also. Now next question comes, the moment the patient of osteopenia comes to you, before the treatment, they will ask, so how frequently we should do DEXA scan? The studies have been recommended that surveillance DEXA scan for post-menopausal female and elderly male beyond 65 to 70 years of age, if their T-score falls between -1 to -1.5 every 5 years, -1.5 to -20, 3 to 5 years, and if it is less than 2, then every 1 to 2 years. But what is important for us is not this. This line is very important for us as a rheumatologist because most of our patients, we give steroids. And if the steroids are, say, prednisolone, more than 5 milligram for more than 3 months, we must do DEXA scan within 1 to 2 years, depending on the patient. Your clinical sense will also come into play in this. So what are the indications? The last slide, the tips are like here. Any patient of osteopenia, if he or she is less than 50 years of age, you have to treat that osteopenia. Why? Because they are more prone for low impact of fragility fractures. As I gave you the example of their grandmother-grandchildren. And the other example is that the lady working at home, say around 45 to 48 years, suddenly her foot is twisted and there is a pain and swelling which is diagnosed as a case of fracture of metatarsus at the later stage. Not immediately, because we do not think that the patient had any fracture. So those are the ladies or those are the patients we should treat osteopenia. And any long-term steroids, like in cases of bronchial asthma, COPD and interstitial lung disease, because they are there on steroids for longer time, beyond 3 months. They take it for years together. And of course, again the most important line, high-dose steroid treatment. As a rheumatologist, all of us, we know that certain diseases, they demand high-dose steroids initially, like Vaginus or GPA. We give pulse therapy. We give pulse therapy in SLE patient with major organ involvement. We give high dose of steroids initially in myositis. We give high dose of steroids in sarcoidosis. Leave aside that. In cases of SLE or in rheumatoid arthritis, to maintain sometimes, or in cases of myositis, for 1 year, 2 years, maybe 3 years, we have to give prolonged steroid therapy. Those are the candidates. If they are having osteopenia, please treat the osteopenia with those drugs. And of course, patients of CA, breast and prostate who will be or who are planned for hormonal therapy. Last but not the least, any patient of osteopenia with strong family history of osteoporosis and parental fracture, please treat. That's all the tips I wanted to give. So they say repetition, practice makes man perfect. So this was a repetition of all the speakers which I told, and I believe that repetition makes the brain perfect. Thank you, ladies and gentlemen. Thank you very much. I think as a chairperson also, I have to prevent my call by going there. I declare this session ended. Thank you very much.